Is it disc? Is it facet? Is it muscle? Is it ligament? Doesn't really matter a lot, because if it happened within a certain amount of time, let's say within a week or two, you can suspect that it's likely to be recovery by repair, and they all benefit from movement. You end up doing the same treatment, basically, which is wonderful, because clinic is a very complex environment, and we really want to simplify it a lot, and that allows you to do this huge jump.
FC2O. From chaos to order. From chaos to order. Here we go. From chaos to order. From chaos to order. FC2O.
Dr. Eyal Lederman is our guest this week on FC2O. Eyal has been an important voice in the Manual Therapies, calling for a more active approach to helping patients recover from or adapt to their presenting conditions. Eyal is not shy of controversy and has written many papers over the years questioning key tenets within the Manual Therapies, from the use of manipulation to the benefits of core stability to what he terms the fall of the postural structural biomechanical model in manual and physical therapies. In this dialogue, we explored many of these areas. Now, I'm always keen to respect my guest requests, and in this instance, Eyal has asked me to edit out a number of sections totaling about 30 minutes. So the podcast is a little shorter than normal, and you may notice a slight lack of continuity here and there. My hope is that we will be able to meet again down the line to revisit some of these more challenging areas of discussion. Enjoy the show. Here we go. All right, so welcome to another edition of FC2O with me, Matt Wallden, and my guest today, Eyal Lederman.
Thank you, Matt.
How are you doing, Eyal?
Yeah, I'm very well. Thank you for the invitation to speak.
Well, thank you for coming along. I should probably let people know this is our second attempt because we had a bit of an issue the first time round. But so thank you very much for coming back again. I think, I really loved the last time we had a chat. There was so much great information in there. So I'm excited to go back through some of that again, and we're going to try and just do a fairly brief introduction. So I think what I'd like to do, Eyal, I know many people will know who you are and know of your background, but I also will have some listeners who don't know too much about your background. So if you could just give us a quick rundown of how you got into osteopathy and then sort of where that led you from there.
Okay. Studied life as a yoga teacher and got very interested in bodies and how they work. I found out that about the time I found about osteopathy and got very curious about it, and eventually came to London to study it. Mm-hmm. I finished in 86, so I've been in practice for a long, long time. Mm-hmm. And I still work in practice. Soon after I graduated, I also started doing research that eventually led to doing a PhD. It was the time there were no PhDs in osteopathy, so it was a collaboration between King's College London and the British School of Osteopathy at the time. And that was, I think, one of the first kind of collaboration between the two professions.
Right.
But I also run the Center for Professional Development in Manual and Physical Therapies. So we run courses throughout the year. So I spend a lot of time there. I'm still involved in research. I just finished a PhD dissertation. Someone finished her doctorate looking at functional movement rehabilitation for people who had knee replacement. Mm-hmm. And this was done at Stanmore at UCL, at the orthopedic hospital. So that was last year. Yeah, I'm now looking for another project.
So if anyone's got any ideas.
I got the ideas. If anybody's got the money.
Right.
Much better.
Yes, exactly, yeah. Okay, so does that, am I right in saying, so was that a second doctorate, or was that a doctorate you were working a lot on?
No, I was supervising. An osteopath. An osteopath who she was doing her, Yelena, she was doing her doctorate, looking at functional rehabilitation.
Yes, okay.
Something we'll talk about it probably during the the podcast.
Yeah, perfect. And also, I'm not sure if you mentioned your books, but you've written several books.
Yeah, I've written the Fundamentals of Manual Therapy was the first book that was written in the early 90s. It was due to my frustration with osteopathy to a point that there was very little information on how techniques work, the physiology of techniques, what happens with them, how do they affect the body. All that information was very not well understood. I wasn't happy with that, and I had to clarify it for myself, and that was the consequence was the book. And then that developed into the science and practice of manual therapy, harmonic technique, the neuromuscular rehabilitation, which was a new take on movement rehabilitation, which was the consequence of my research. My own PhD research was into the neurophysiology of manual therapy. Do manual techniques have any effect on motor control, motor system? The bottom line is they don't. We need to have an active approach, and that kind of led to this new approach in osteopathy.
Yeah, fantastic.
And that led also to the functional stretching book, also because the sciences were demonstrating that clinical stretching were not that effective, and that we need to look at it in a completely different way. And that was the consequence of that kind of research that came around. And I'm now struggling to write my sixth book, and that's about functional exercise prescription.
Right.
Which is, the idea is how to exercise without exercising. Can we use normal human movement, i.e. daily activity, to rehabilitate people? And that's largely because people don't do strength and conditioning exercise. It's very difficult to convince patients who may need it, have a dramatic need for this for exercise interventions. There's very little compliance and adherence to this kind of advice. So kind of turning the whole thing upside down and looking at it that any human activity can be amplified or attenuated in some way to provide physical challenges for rehabilitation of movement.
Yeah.
So this is what I'm kind of my big passion at the moment is.
Yeah, great. And it sounds like I mean a lot of the information I've been reading, in the pain literature, pain neuroscience, and so on, is really talking a lot about the idea of a meaningful task and identifying meaningful tasks, and then building the rehabilitation around that. And that sounds very much like what you're
100%.
Yeah.
One of the first questions I ask my patients is, what would you consider to be a successful treatment? What would you want out of this treatment? And that's it. That's what determines the whole program.
The
construction of the treatment also.
Yeah. Right. And so, I know you just touched on it in your sort of introduction there, but one of the first things that I remember picking up from you was this idea that and it relates to treatment as well as to rehabilitation to some degree, but the idea that passively applied techniques, like most manual techniques, with the odd exception. So I think you might say MET, for example, or contract relax type techniques do have an active component to them, obviously, but a lot of other techniques such as mobilization, manipulation, articulation, massage, NMT, STT, soft tissue technique, they are very much passive, and so can you just explain why that's a bit of an issue in the longer term? Because obviously that's been the way people have been treated for many years, isn't it? Many decades.
And that's part of the problem that we have in osteopathy. We didn't have, as a consequence, any kind of rehabilitation or exercise prescription management of patient. So the treatment was mostly a passive treatment. And very rarely in the past, osteopaths used to give exercise. When I was a student, there was no active component to the course. We didn't know what exercise we should give our patients. And only in the last year of osteopathy, we had a physiotherapist come and teach us what is a kind of traditional physiotherapy exercise. But otherwise, we had zero input. And so when I started doing my research into the neurophysiology of manual therapy, I started scanning all the other methods
Yes.
and seeing that there are problems everywhere. It's not just for osteopathy, but even the methods that were used in physiotherapy and so on,
Mm.
they needed updating, basically.
Mm-hmm.
There
Mm-hmm.
were problems, and this is where I'm at now, because it's kind of developing to more functional approaches.
Yes.
But the essence of it is that you can't learn movement or enhance it in any way or develop it if you are not actively doing the movement.
Mm-hmm.
It's in the same way that you can't learn movement while you sleep. It just wouldn't happen.
Yeah.
You need to be actively engaged
Mm-hmm.
and correcting the movements. So this kind of correction and creating the maps for the movement
Yeah.
is an active process. It doesn't happen with passive stimulation.
Sure. Sure.
I mean, it's actually a very long story, but basically that's the essence of it.
Yes. Yes.
So adaptation in any kind of neural system is an active process. You need to be actively doing something to facilitate this kind of plasticity, and
Yes.
it doesn't
Absolutely.
happen by just passive. If you do passive techniques, all we are doing is providing feedback to the
Mm-hmm.
system,
Mm-hmm.
but it's not activated necessarily. It's not responding, not
Right.
doing something about this feedback, that's the important bit. You need an afferent, an input, but you also need at the same time afferent output,
Yes.
and you have to couple them together,
Yes. Yeah.
which
Absolutely.
brings which creates a very interesting phenomenon.
Mm-hmm.
If you learn some in one modality, you can't really doing it that same modality. But what you did to say to walk across a plank with your eyes shut. Um, if we then, and you learn to do it with your eyes shut, once we ask you to do it with your eyes open, you might not be as good as doing it with your eyes closed. It will take you to readjust again.
Hmm.
So what I'm trying to say is the sensory information that comes in and the output have to all the time be coupled together.
Right.
And that's why there's no
Right.
transfer. There's no
Yeah.
transfer of sensory information. So what you learn in one activity doesn't necessarily transfer to another one.
Now, part of where we're sort of leading the discussion is that, of course, your most recent, I guess, concept that you've developed is this process approach. I
Yeah.
believe. I mean, you're probably developing new stuff all the time, but this is what your focus has been on fairly recently.
Yeah.
And again, within that, of course, what we were just discussing, that the focus must be much more active and much less passive as far as the patient's concerned.
Not necessarily. It depends on the process you are dealing with.
Okay.
So let's go there for a minute
Mm-hmm.
to a process approach. What is a process approach?
Yeah.
The most kind of basic, if we had to somehow look at the bottom line of osteopathy, what osteopaths do is we believe that the body has the capacity for self-recovery, self-health, and so on.
Mm-hmm.
And that's the basis of everything we do from there on.
Yeah.
What was missing for a long time is that we didn't identify what are these remarkable processes. How do people get better?
Mm-hmm.
How do people get better after an injury? How do
Mm-hmm.
people get better after a stroke
Mm-hmm.
or after immobilization? How do people recover after chronic pain? What are the mechanisms there?
Yeah.
And so that's what I set out to do.
Mm-hmm.
And basically, there are three key processes associated with functional recovery. Functional recovery, let's define that first maybe,
Mm-hmm.
is your ability to maintain, carry out daily activity in some effectively, efficiently, and some level of comfort, let's say.
Yeah.
Kind of, but so that's functionality. That's what I mean by that.
Mm-hmm.
And so the return to functionality after some kind of condition depends on three different processes, overall processes. So one is repair,
Mm-hmm.
the other one is adaptation,
Yeah.
and the other one is modulation of symptoms or alleviations of symptoms.
Yes. Yeah.
So, and they kind of, if you can imagine a Venn diagram, which you can probably put on the
Yes. Yeah. Yeah.
podcast
I can do
somewhere,
that. Yeah. Yeah.
yeah. They all overlap, of course, so you can have several of these processes happening at the same time.
Mm-hmm.
So in a process approach, we ask a very simple question. When a patient comes in, by which process is this individual going to recover their functionality? That's all.
Yeah.
Now, if you can define that, you're onto a winner, because
Mm-hmm.
there has been a lot of research around these three overall processes. So we actually know a lot what we need to do in order to help people recover.
Mm-hmm.
So if we look at, so we're looking at how to create ideal environments for each of these processes. What is the ideal stimulation for repair?
Mm-hmm.
What is the ideal stimulation and support for adaptation and for modulation of symptoms?
Yeah.
And when I'm talking about environments, I'm talking about the environment, that outside environment, the physical environment, the person's relationship to their environment,
Mm.
and their body also as part of that environment. So we're looking at psychology, behavior,
Mm-hmm.
culture, and all those kind of things. So this is what we are looking for.
Mm.
So when a person comes in, let's say a person came in with an acute disc problem.
Sure.
It's very clear that that's what the case,
Mm-hmm.
and it happened in the last say 2 weeks ago.
Mm-hmm.
So I would immediately ask myself a simple question: by which process is this person is going to recover? Is it adaptation, repair, or modulation of symptoms?
Mm.
Um, so largely we are dependent on repair processes because they had some kind of tissue damage,
Mm-hmm.
and this is what is happening there.
Yeah.
So this is the main process.
Mm.
And the question then is, well, what does the research tell us about repair? What do we need to do in order to support repair? As a physical therapist, keep on moving.
Mm-hmm.
Movement is
Mm-hmm.
very, very important for that,
Yeah.
amongst other things. But this is the most important key point.
Sure.
Now, if you start thinking like that, it actually simplifies your management a lot also at the same time.
Mm-hmm.
Because repair is universal in the body. So no matter where there is tissue damage, there is a repair process going on.
Mm-hmm.
So if they all require the same management,
Yeah.
you don't really have to have a tissue diagnosis
Okay.
anymore. So say the same patient came to your clinic with acute lower back pain.
Mm.
Is it disc? Is it facet? Is it muscle? Is it ligament? Doesn't really matter a lot,
Mm.
because if it happened within a certain amount of time, let's say within a week or two, you can be you can suspect that it's likely to be recovery by repair, and they all benefit from movement. You end up doing the same treatment basically,
Mm-hmm.
which is wonderful
Yeah.
because clinic is a very complex
Mm.
environment,
Mm-hmm.
and we really want to simplify it a lot.
Yeah.
And that allows you to do this huge jump. So you don't have to have tissue causing symptoms anymore.
Mm-hmm.
You
Mm-hmm.
just need to understand, to guess which process may be taking place
Yeah.
for
Yeah.
recovery.
Mm.
Now, the whole management would change dramatically if we had someone who's, let's say, had been immobilized in a plaster cast for two
Yes.
months. Once the plaster cast is off, we're no longer in the early phases of repair anymore. We're more in the remodeling or
Mm-hmm.
the adaptation phase.
Yeah, yeah, yeah.
Now,
But before we jump into that, El, could we just elaborate a touch? I really like the way you're taking this, but with the repair side, when we've got this idea of an acute injury and the repair is fairly predictable from what we were just discussing, would you also incorporate other elements such as nutrition and hydration and sleep and those kinds of things, or would you assume that that's kind of being handled by the patient themselves? Is that something that you get into or you refer out for that kind of thing, or do you not really
I,
consider that so much?
no, no, it's fairly robust, the repair process.
Okay.
You really have to be malnourished or have serious chronic illness
Mm-hmm.
to affect your repair process.
Okay.
And that doesn't happen in North London, not where I live.
Doesn't.
No, it doesn't.
Okay. Okay.
So now I don't get into those.
Yeah. Got it.
Also, you have to consider that the more information you give your patient, the more we are likely to confuse them.
Right.
Um, because we know that 80% of the information that given after a session is forgotten.
Yes.
50% is remembered erroneously.
Yeah. Yeah.
So the more we pile, we make it more and more complex. It becomes more and more difficult for the patient to understand what's wrong and how to manage it. I mean, it just adds layers and layers of complexity to something that can be straightforward.
Okay. So yeah, let's go back to the plaster cast.
I'm not saying that it's wrong to look at diet, but it might not be necessary.
Yeah. Okay. That's fine. So let's go back to the plaster cast discussion. So the person's just had their cast off. Obviously, they're now more into the adaptation phase.
That's right. So it's a remodeling phase of repair. The latter phases are more to do with reconstructing the tissue. That reconstruction of tissue, recovery of range of movement, and recovery of motor control are highly specific. So you want to be very, very close to the activity that you're trying to recover, rather than far away from it. So if it's, say, walking, you're trying to recover. Remember, our patients have different goals than us. We quite often think of we need to improve plantar flexion and dorsiflexion.
Yes.
All the patient wants is to be able to walk up and down stairs. So they have a very clear goal, which is different from our goal. So now what it means is that traditionally you would get them onto a machine that does some kind of plantar dorsiflexion.
Right.
You can take that element out of the functional task and practice it outside the functional task. Now, the problem with that is that it doesn't transfer back. All that happens is that our body is a very obedient servant in some way. It will do what we ask it to do. So we'll get very good at doing a plantar dorsiflexion on a wonderful, shiny machine. In the context of, say, a gym. But it doesn't necessarily transfer to, say, something like walking up and down stairs.
Yes. Yeah. No.
I mean, even things that, really simple things like balance. I'm just reading around balance and specificity of balance. It's something that I've looked in the past, but there's a lot more research now. It's totally non-transferable. It cannot be. So, and you can't even measure people balance by asking them to stand on a single leg, because it doesn't represent the balance of walking or going up and down stairs. So each one is a unique balance program, and you have to practice the real thing. If you practice something away from that, which is dissimilar to the goal activity, it just doesn't happen. Or let's say, if it does happen, it's not the most effective way of working.
Sure. Okay. Something I was going to say about adaptation, but it's just slipped my mind at the moment. But yeah. So are you going to elaborate further on the sort of adaptation process, or how you facilitate that?
Basically, it's about exposure. You need to expose the person to the activity often. So that's why we have to engage them in that activity. And so that's exposure, so repetition. And the other thing is specificity. It has to be specific to the goal. It has to be very, very similar to the real activity. The principle is you can only learn what you've practiced. You can't learn what you've never practiced.
Yes.
So if we are doing some exercise on a machine, we get really good at doing that, but we don't necessarily get good at walking, which is the goal activity.
I remember what it was I was going to say. I actually supervised a thesis quite a while ago now, probably 15 years or so back. But the guy was, what he was assessing was MET, so contract, relax, stretch to the soleus, to see how that would improve, obviously, range of motion, range of dorsiflexion at the ankle joint. And then he was comparing that with a group that just did squats. And what he found was they both improved, but there was no statistical difference between the two. So in other words, because you were demanding the range of motion through doing the squat-based activity, the Soleus was adapting to that, but it was there was no statistical difference between
No.
the treatment group and the guys that were doing the squat. So in other words, you're as well to do the activity, which is exactly,
Absolutely.
I think, what you're saying there. Yeah.
Because it works on exposure and repetition, the whole adaptation process is driven by the fact that we do it often.
Yes.
If you think that if a patient comes to our clinic and let's say your treatment is half an hour, the MET part is let's say 3 to 5 minutes out of that, if that.
Yeah.
Now there are 168 hours in a week,
Yes.
and you've stimulated for 5 or 10 minutes out of the 168, whatever.
Yeah.
It's very, very ineffective way of working.
Absolutely.
The difficulty is it's very difficult to then teach the patient to do it correctly in any way, so that they can't do MET on themselves, but they can. But it's really difficult for a person to learn to do that correctly, if you want. So it's kind of doomed to failure because.
Yeah. It's something that I remember reading a paper on. I can't remember the authors, but it was 1998, and it was the first time I'd read the idea that muscles may be tight for a reason, and essentially what it was saying that when you have and again they were looking at Soleus in runners, and they were making exactly the point that you were making. That if you stretch for even 5 minutes, which most people would not stretch for that long, but then you go out for an hour's run. Well, the stimulus on the body, is it going to be more towards tightening the soleus because you're running for an hour, or is it towards stretching the soleus because you stretched it for 5 minutes? And there's the kind of counterbalance there is quite obvious that it's not sufficient, but also
it's basically a competition in adaptation.
Exactly, and then they point out that the tension there optimizes stability at the joint. It optimizes recoil. The recoil happens sooner, so therefore you end up with a more efficient gait pattern, and so on. So they listed all of these things, and it was a bit of a moment where you look at it and you think, yeah, this is interesting, because for so long the idea was that, if you're going to do a sport, you can do something active, you must stretch beforehand, and of course. Yeah. That really doesn't have any real, doesn't make any real sense from an evolutionary perspective either, does it? That makes no sense. Yeah.
If you're in the middle of a savannah and there's a tiger, coming at you, you don't stop and do your 5 minutes of yoga stretches to make sure that you are warmed up and you are now agile enough to run.
That's it. Yeah.
We are really evolved to function maximally within milliseconds because it's such a survival essential.
Yeah.
You can't afford to warm up, which also brings up a big question. What is the human warm up?
Yes.
Are we stupid humans the only animal on the planet to do a warm up? Why are we doing that? Does it have any value? Is it psychological? Is it physiological?
Yeah.
Does it really do anything?
Yeah.
It's interesting questions, but
yeah, they are very interesting.
They trouble me a lot, these kind of questions.
Yes, exactly. So look, one of the areas where I think a lot of the guys that obviously listen to the podcast are from the Czech training that I've been involved in and practice for many years now, and one of the things that we talk about is this idea of isolation to integration. I know you don't subscribe to that. Are you able to explain? You've already touched on it, but you're able to explain a little bit more why that doesn't make sense from your understanding.
Okay, so when we learn, when you learn a task, say to reach for a cup, there are two components to it: the task, the goal of the task to reach the cup, and the movement that you use for reaching the cup. Okay. Now, so from very early age, we associate it's integrated basically the task and the movement that we use for it.
Yes. Yeah.
We don't have to think about it. So if I ask you to reach for a cup now on the table, you just reach for it. You wouldn't even know that you are doing it almost. It will be something in the back of your mind.
Yeah.
So the movement and the goal are fully integrated. Okay. Now, when we start asking people to focus on their body, we are doing a strange thing. We are disassociating you're disintegrating the task and the movement, or the movement from the task.
Yeah.
So when you disintegrate
Mm-hmm.
the movement from the task,
Yeah.
you actually degrade rather than enhance the movement or the task. So the classical one which they did is they ask two groups to lift a dumbbell to a certain height, and one group is given an external focus of attention, i.e. just focus on the goal, and the other group is given an internal focus of attention, focus on your arm, what it's doing while you're lifting. So that's an internal focus. So they're focusing on the movement also, not just the task, the goal.
Yes. Yeah.
So they're disintegrating it. And what they find is that people who use an external focus of attention, their EMG activity is less. They are doing the same activity a lot more efficiently.
Yes.
And it also has consequences for transfer and learning and so on. And this has been shown quite consistently for the last probably 10 or 15 years. It's a very well-established thing. So we know that actually we do know that movement is organized as a whole. The whole body is organized in one goal.
Yes. Yeah.
Even bits that are not moving are inhibited in some way. So it's an active brain process. The whole map is drawn for that movement.
Yeah.
Now, what we then do is we disintegrated the movement, and then what we do is we then fragment the movement into smaller bits. So it's kind of two levels of separating what you're doing from the goal.
Yeah.
First of all, you took the movement away from the goal, practice the movement on its own, and then you are taking the movement and saying, now we're going to look at individual muscles. So there's further kind of lower dismantling the whole thing.
Sure.
And the brain just hates it. So what is happening in reality is, let's say you give someone a dumbbell and you show them how to do bicep curls.
Yes. Yeah.
Remember, the body is a very obedient servant. So yes, you're activating that muscle, but the rest of your body is also doing something, of course. It's only in our mind that we have separated it in that way.
Yes, yeah.
But what is happening is, again, you're getting this problem of specificity. You're just learning to do bicep curls really, really good, really well. But it doesn't necessarily mean that if you have a frozen shoulder, it will help you to scratch your head.
Yes, exactly. Yeah, yeah. Okay.
It wouldn't transfer.
Yeah.
So it has problems with transfer. It actually degrades movement when we do all this fragmentation.
Yes, yeah. Okay. So I remember going on.
My counter kind of strap line is integrate in order to coordinate.
Integrate. Yeah. Okay. I was going to say I remember going on a course with Shirley Salmon, the physiotherapist, and she was explaining similar to what you're saying, that when cause it was a shoulder course, and she was explaining that, of course, you get winging of the scapula is quite a common movement, which she would call a movement impairment syndrome. And of course we know that when the serratus anterior is inhibited or paralyzed, that we get this winging of the scapula or weak. And so she was making the point that there was a research study that she referenced which was showing that if you do what's called a push-up with a plus, and so it's a standard push-up, but you just go a little bit further, and that activates the serratus anterior, so it conditions the serratus anterior. And she was making the point that you can do as many push-ups with a plus as you want, but it's not going to change the movement pattern of the scapula when, let's say, you reach for a cup in the cupboard, like you just were giving as an example,
exactly,
right? Because it's a completely different pattern. And
so, but what's interesting is I had a look at her book, for example.
Yes, yeah.
Her exercises are anything but functional.
Well, yeah.
And you see that a lot, actually, in movement rehabilitation. Everybody knows the science, but when it comes to the practice, it remains very traditional, very what I would call extra functional movement, i.e., exercise or activities that the person has never been exposed to.
Right. But so then I saw,
and that's a problem. And that's not only just this book. If you go to any library and you look at the rehabilitation books, it's all invented exercise.
Yes.
And the more outlandish the exercise is,
Yeah.
for some reason, we give it higher value.
Right. Yeah. That's just the human
Of course,
condition, isn't
ability of
it?
yeah.
Yeah.
When you talk about modulation of symptoms, this
Yeah.
is the third, for in a process approach,
Mm-hmm.
you can have a pathology, but not feel it.
Yes.
Okay,
Yeah.
so if we scan any of our bodies, we'll find multiple pathologies
Mm-hmm.
which we are not aware of.
Mm-hmm.
Okay, but that doesn't mean that we are so functionally we are all right. So let's take that as an example.
Mm-hmm.
A patient comes to you and they've got chronic lower back pain.
Mm-hmm.
They had it for a year or 2 years or 10 years, doesn't matter.
Yeah.
You do your treatment,
Mm-hmm.
whether it's active, whether it's passive, and they get better within a month.
Mm-hmm.
Okay, you scan their back before, you scan the back after. Would you see any differences?
Probably not. No.
The answer is probably
Mm-hmm.
not. So the question is how can we recover from such deep pathologies,
Mm-hmm.
recover our functionality, and that's the third mechanism that the body does is that it can modulate what we experience as pain
Mm-hmm.
very, very effectively.
Mm-hmm.
And that can happen reflexively, like the pain gate mechanism, spinal processes,
Mm-hmm.
upper kind of spinal, and then kind of higher centers processes. So it's very, very complex.
Yeah.
But the body can do that very effectively. And so when you start looking at pain, this is what I said, it's like the Game of Thrones. Anything works. It's all fantasy land, and so you can do manual therapy and it works. You can do cranial,
Mm-hmm.
and the cranial person tell you it works for me really well. And you
Mm-hmm.
do spinal manipulation, it works really well. And you
Yeah.
do core stability training and it works really well. Not as equal as walking, so of course. But in that dimension, we are not working with certainties as we do for, say, if we know that someone can't walk, we know that we need to get them up and walking.
Mm-hmm.
It's quite clear the physiology and what we need to do. But when we talk about modulation of symptoms, this is what I was talking about. The next decade for me
Mm-hmm.
is understanding how people experience pain
Mm-hmm.
and their kind of belief systems,
Yeah.
and how we can work with those systems to switch off pain. But it's nothing to do with motor control, of course.
Okay. Yeah, but it is to do. I mean, again, we touched on this last time we spoke, and I'd like to bring it up again. Is that it is very much to do with the patient taking the reins and being more active, and actually giving them tools to get themselves better, isn't it? That's got to be part of the process, rather than it being a dependency on an extrinsic device or individual or whatever.
Yeah, interesting
Right.
thought, isn't it? So from the research, we are told that the patient should be kind of independent of us.
Mm-hmm.
They should be dealing it with themselves. It's fantasy land.
Mm-hmm.
It doesn't happen. People need other people to help them to get better.
Yes. Yeah.
Quite often, what I see in clinic, and pushing them away to self-care can work
Mm-hmm.
for some people, but not everybody.
Yep.
They need us to contain their fears, to reassure them, to create a structure for them to recover.
Mm-hmm.
And that's what a lot of the research doesn't see. So I'm having doubts with that, let's say, this whole model. So some patients absolutely need me to be there for them.
Yes, yeah. So more like a coaching model, with maybe some treatment thrown in, or I suppose it's going to vary from person to person. But
that's right,
yeah.
But it's we have to be careful with that idea that everybody can self-care and just give them a sheet of exercise and they'll do it at home and everything will be fine. It doesn't work.
Yeah. Sure. Good.
So process approach.
Yes.
I don't know how we got to core stability training, but basically 3 basic processes: repair, adaptation, modulation of symptoms. If you can identify the process by which your patient is getting better, we have very clear guidelines what can be done to provide a supportive environment.
Yes.
It's actually quite straightforward. We've overcomplicated something which is we do naturally anyway.
Sure.
Basically, all these processes pre-exist us.
Yeah.
So people do adapt, people do repair, people do modulate their own symptoms.
Mm-hmm.
We are there to just kind of amplify these effects, these processes, support them.
And what level do you go to in this? Because I know I'm just looking at the sort of outline of the model. So we've talked about recovery processes, we've talked a bit about behaviour, psychological factors, not so much. But do you work on those again within the treatment session, or do you refer out to other specialists to help you with the psychology side of working with?
No, I do the kind of the psychological intervention is more about reassurance. It's more simple things. It's not deep psychotherapy.
Yes, yeah.
So, some cognitive tools, not too many of them. But I'm attentive to the patient emotional and psychological state.
Yeah.
And kind of respond accordingly. But,
sure. And when
more than that, I don't know. I don't refer very rarely. My wife is a psychotherapist, but
yes.
referral between us is close to zero.
Right.
Very, very rare.
Yeah.
But I do learn a lot from her about the psychology and management of patients. She's an expert on that.
Yeah. Excellent. And so, if people want to learn more about how to apply the process approach, or indeed any of your other approaches and courses that you have, where's best to go to?
The best is to go to our website, www.cpdo.net. If you can have it also on the website.
Yeah, I'll pop that up. Yeah, no problem. Excellent.
And books they can find on Amazon or on our website, but all the information is there on that website.
Fantastic. That's great. All right. Well, thank you very much for that today, Eyal. I hope it wasn't too combative. I wasn't trying to be too combative, but I was trying to reconcile my understanding with where you are at as well. And I think we've got some interesting headway there. I still will take you up on that offer. I have to come on to one of your courses and see if I can be fully convinced of some of these more sort of finer points in motor control and so on. But that's great. Thank you for sharing your time and your experience.
All right,
and
thank you for the invitation.
Look forward to our paths crossing down the line.
Yep. All right.
Great.
Thanks for that.
Great stuff.
Bye-bye.
Thanks.
Bye.
Take care. Bye-bye. So there you go, short but sweet. As you'll have gathered, I have a lot of respect for Eyal, for his work, for his willingness and courage to swim against the tide, and because he's a great guy. We have some differences of opinion and understanding in certain areas relating to posture, motor control and so on, which we will hopefully get back to further down the line. But overall, I find his process model of working with patients a great concept and a beautiful example of someone who's found simplicity on the other side of complexity and helps move us from chaos to order. Thanks for joining us on FC2O. See you on the next show.